Suresh garu. Okay.
Start చేద్దాం. Good morning all. Today Dr. Mohan Rao is going to talk on autoimmune encephalitis. Previously, when our patient comes in unconscious state without any proper history, their attendants may said, yes, that patient is unresponsive, found unresponsive, and the age is no bar from child to even extreme age. Very young patients also coming with unconscious state. All the tests are negative. Whatever you do, the MRI or the CSF analysis and other blood investigations are also not giving any information. In that condition, sometimes we will tell the relatives that all the tests are negative, nothing is there, just continue antibiotics and see what is going to be. But that is not sufficient enough. Dr. Mohan Rao sir is going to explore some more what exactly any rare possibilities of this condition. Is going to explore on that and enlighten on autoimmune encephalitis causes, what is the treatment for that. I request Dr. Mohan Rao sir to start the presentation.
Dr. Suresh, good morning everyone. Thank you, David. As David said, last 10 to 15 years, actually, we have been treating patients who are coming to the intensive care in a late stage, like refractory seizures or in a coma, and we are unable to diagnose the cause for these refractory seizures, or epilepsy, or a coma. And last 10 to 15 years, the science evolved like anything. This thing, autoimmune encephalitis, came all over the world, and in particularly in few countries, they formed society to develop this develop and research and identify new antibodies which are mainly affecting this autoimmune encephalitis. As a definition wise, it is a encephalitis. Acute encephalitis is a rapidly progressive encephalopathy, usually less than 6 weeks, caused by brain inflammation. And as David said, most frequent cause for this encephalitis are infectious. But last 10 to 12 years, the increasing causes for encephalitis are going to towards the non-infectious. In this, one of the causes autoimmune encephalitis, which is closely resembles like a infectious encephalitis with the clinical diagnosis, similarities in clinical imaging and laboratory findings of many forms of autoimmune and infectious encephalitis. So, having said, this autoimmune encephalitis is a potentially reversible cause of status epilepticus, epilepsy, and cognitive decline. So, begin with my talk. I will present in front of you one case. This is a 60-year-old man presented with confusion, agitation, tangential speech. In this patient's brain MRI shows left hemispheric cortical urbaning, concerning for encephalitis, seizures, and prion disease. EEG showed left hemispheric slowing but no epileptic activity. As a routine, toxicology and infectious workup were negative, but CSF was positive for anti-NMDA receptor antibodies. Similarly, they did oncology assessment for unrevealing causes, so which is also became negative. So patient received 5 days of intravenous methylprednisolone and improved attention, ability to follow commands, and engage in appropriate conversations. So this is the pattern, one of the pattern of presenting the autoimmune encephalitis patient to the intensive care units. Early days also, the people tried with steroid, but they tried in a late stage, and they tried with immunoglobulins also. By that time, the damage has happened. So, autoimmune encephalitis is a group of conditions that involves inflammation of the brain. The
Sir,
inflammation
before
is one
that,
of
sir,
the
sorry to interrupt you, sir.
sir.
Sir, how was cells and glucose and protein in this patient?
So
CSF?
I tell you, sir, the diagnostic algorithm, everything.
In this patient, sir.
This patient, yeah, and just a framework like I put there, sir.
Okay, sir. Right, sir.
So this inflammation is one of the way that our immune system protects the body from the infection. What happens? Autoimmune encephalitis, the immune system mistakenly attacks the healthy brain cells. This leads to so many neurological and psychiatric symptoms. So our immune system attacks the different parts, almost all different parts of the brain. It affects neurons, synaptic clefts. So this leads to presentation with the neurological and psychiatric symptoms. So it presents a wide range of symptoms. One interesting thing is not every patient with autoimmune encephalitis will have the same symptoms. That is a very dilemma while diagnosing the autoimmune encephalitis. But certain symptoms and the pattern of symptoms lead to suspect this diagnosis. So that is why we have to keep mind this pattern of symptoms and certain symptoms particular to the autoimmune encephalitis. So most of the time, because of this wide variety of symptoms and presentations, this so far autoimmune encephalitis, most of the times is misdiagnosed or underdiagnosed. So this is the slide showing the normal nerve cells with the anti-NMDA autoimmune encephalitis, nerve cells in a non-anti-NMDA autoimmune encephalitis. So what happens in the nerve cells at the synaptic club? This is the presynaptic bulb of nerve cells and its postsynaptic bulb of nerve cells. When electrical impulse comes, it stimulates and the vesicles containing the neurotransmitters are released, which are attached to the receptor channels and opens and allows ions passes through the channels and generates the impulse. So this is the way of the neurons are working at synaptic cleft. So what happens in autoimmune encephalitis? There are more than 15 antibodies they've identified. These antibodies have different targets and damage cause may result in a different types of neuronal dysfunctions. So antibodies may launch an attack on neural receptors. Because of antibodies may recognize molecular similarity between the parts of the neuroreceptors in the antigen, which is the antibody has encountered inside and outside the brain. So mostly surface antibodies are there, intraneural antibodies are there, synaptic antibodies is there, and different types of antibodies which attacks the different types of antigens in the neuronal cells, which leads to variety of symptoms presentations. So based on this, actually they came up with a classification of the autoimmune encephalitis based on anatomical classification, based on serological diagnosis and classification, and etiological wise classification. So based on the anatomical classification, by seeing the MRI, they have classified as a limbic, cortical and subcortical, striatal encephalitis, diencephalic AE, brainstem, cerebellar encephalomyelitis, meningoencephalitis, and combined. So if you see, most of the brain parts are effects in a different of autoimmune encephalitis. Coming to the serological classification, this is mainly classified based on the type of antibodies we detected in the serum or a CSF. So also they have classified based on whether it is affecting the surface or intracellular or a synaptic cleft, and also they kept a group of seronegative autoimmune encephalitis. So mainly antibodies to intracellular antigens, which are classical onconeural antibodies, which usually affect the intracellular targets. The prognosis was very poor in these conditions. because this leads to cell damage, permanent cell damage. This is mostly associated with tumors. And second one is the in serological classification is antibodies to surface antigens and other antigens with high clinical relevance like NMDA, AMPAR, LGI1, CASPAR2, GABA A and 2. And another one, third group is antibodies to surface antigens with low clinical relevance like VGKC, VGGC. And fourth group is seronegative autoimmune encephalitis. In this, all features are sets, but antibodies are negative. Another is the etiological classification based on idiopathy. We don't know cause, associated with paraneoplastic. Third one is post-infectious. Sometimes we can encounter post-herpes simplex. Another is heterogenic in the setting of any immuno checkpoint inhibitors or other immunomodulating agents. So with this, moving to the what is the difference between autoimmune encephalitis and infectious encephalitis? Coming to clinical presentations, autoimmune encephalitis people present with psychosis, language dysfunction, autonomic instability, movement disorders. Around 50% have a fever, but rash is not present. Coming to the similarly infectious encephalitis, as you know, this present with fever, altered sensorium, seizures, and sometimes rash with few infections. CSF findings are in both conditions. There will be CSF lymphocyte pleocytes will be there, but in autoimmune encephalitis, it is very milder, just more than 5 to 10 cells. In infectious encephalitis, this lymphocytic pleocytes is severe. Coming to the MRA, we can find characteristic findings in infectious and autoimmune encephalitis different. In MRA in autoimmune encephalitis, MRA may be normal in anti-NMDA encephalitis. Sometimes it involves the lateral temporal and insulars are less commonly involved, but basal ganglia is more involved in autoimmune encephalitis. Coming to the in infectious encephalitis, basal ganglia is spared. So differentiating feature between the infectious and autoimmune is the MRA by seeing basal ganglia involved or not involved. If it is involved, more towards it goes to the autoimmune encephalitis. How these people present in early stage of symptoms, which is vary from person to person, it's rapidly in a new symptom or a changing of symptoms, and sometimes people will present like experiencing hallucinations, then develop seizures or presents with a memory disturbances. So sometimes these symptoms fluctuate also. So like a alternate between improving or a worsening in the early stage of the disease. So based on these symptoms, most of the people and most of our clinicians also diagnosed as a epilepsy, tic disorders or a psychosis. So the diagnosis part, if you are not properly if you are not taken history, will diagnose in a different way, will start a treatment according to that diagnosis. This is the main problem while identifying the autoimmune encephalitis. So coming to the symptoms, autoimmune encephalitis symptoms are divided into neurological symptoms, psychiatric symptoms mainly. That is why we'll get most of the autoimmune encephalitis from the psychiatrist patients, psychiatrists, because they present to the psychiatrist because of their psychiatric symptoms. So this is the nutshell of the variety of symptoms present to the people present in the autoimmune encephalitis. Like it's starting from the hallucinations, paranoid thoughts, cognitive impairment, insomnia, loss of inhibition, memory difficulties, loss of language, weakness or numbness of part of the body, vision changes, involuntary movements, loss of balance, distorted vision, severe anxiety, psychosis, seizures, finally decreased level of consciousness. In some varieties of autoimmune encephalitis, patient may present with a severe autonomic instability like hypotension and hypertension. So these are the nutshell of symptoms. based on these symptoms also, some people have framed the syndromic approach to diagnose the autoimmune encephalitis, like a alteration of the synaptic function. I will come to later regarding this one. So as the autoimmune encephalitis presents with a prodrome, the symptoms will slowly start like agitation, psychosis, catatonia, memory deficit, speech reduction, and abnormal movements and seizures, followed by coma, hypoventilation, and a dysautonomia. Most of the time, we'll see in this condition in the intensive care units. So if you properly diagnose and if you give proper appropriate treatment, the clinical improvement occur in a reverse direction. So what else can look like an autoimmune encephalitis? As already told, this maybe look like epilepsy, obsessive compulsive disorder, schizophrenia, or a tic disorders. Why do people get autoimmune encephalitis? Exactly, no one knows exactly why people get autoimmune encephalitis. Certain cancers may be associated with autoimmune encephalitis, though they named as a paraneoplastic. Mostly this associated with intraneural antibodies. Infections like a herpes simplex virus, no known trigger in this condition. So previously healthy people also may get AE. Previously autoimmune disease people also may get. Strong family history of autoimmune disease also may chances of getting autoimmune encephalitis. So strong detailed history must be needed in this to diagnose autoimmune encephalitis and pattern of symptoms. So coming to this one, so what happens? The person's own antibodies or immune cells attack the brain in these conditions. So these antibodies target specific proteins or receptors in the brain, which determine the type of autoimmune encephalitis. This may be surface antigens, intraneural antigens, or synaptic proteins. So as we'll come to this slide. So this is the normal cell. In a anti-NMDA autoimmune encephalitis, what happens? The antibodies bind to the NMDA receptors, and receptors absorbed into the neurons, and this absorbed NMDA receptors become dysfunctional in a anti-NMDA autoimmune encephalitis. In other non-anti-NMDA autoimmune encephalitis, these receptors are attacked by antibody channels, not open or allow ions pass through the signals. So there will be no electrical impulse like a normal cells. This leads to electrical impulse not stimulated in a postsynaptic neurons, which causing nerve cells and brain to stop working as they should. So this is the main background pathology behind the mechanism behind the autoimmune encephalitis. So these are the changes we can encounter in a MRI when you do initial stages. Like this is the most of the times it affects the we can see the changes in the brainstem and hippocampal area. This is based on this we can call it classified as a limbic encephalitis. This is the cortical and subcortical encephalitis. This is the straight encephalitis. This is the diencephalic encephalitis. This is the brainstem encephalitis. This is meningoencephalitis. These are the typical bilateral hippocampal flare abnormalities observed in a patient with anti-GABA B associated limbic encephalitis. Characteristic multifocal lesions in patient with anti-GABA A. In B limbic encephalitis, B is in a subcortical encephalitis. So how will you diagnose? What is the diagnostic algorithm for autoimmune encephalitis when patient comes with this kind of history and symptoms? So first, one more thing is that you have to do the brain MRI. So confirm focal or a multifocal brain pathology suggestive of autoimmune encephalitis. So in which brain MRI must, and easy also if MRI is negative or the patient is encephalopathic and having a frequent seizures. Some centers they will do initial parts itself a brain PET. to know the hypermetabolism or hypometabolism of the particular areas of the glucose. If the MRI negative, they will go for the PET. And confirmatory inflammatory analysis, and to rule out competing possibilities, we have to do lumbar puncture and blood test to rule out other causes for these symptoms, ANA profile. And some centers, they are doing brain biopsy if diagnosis remain uncertain. Simultaneously, in a step 2, we have to screen for the associated neoplasms like CT chest, abdomen, pelvis, mammogram, breast MRI, pelvic or testicular ultrasound. Some centers, they will do body PET if initial negative screen comes for the tumors. So this is the stepwise approach to diagnose the autoimmune encephalitis. So based on this, we can classify the autoimmune encephalitis into possible, probable, or a definitive autoimmune encephalitis. Definitive means if you suspect symptoms, patient says a positive for the antibodies, it is a definitive autoimmune encephalitis. For possible autoimmune encephalitis, this criteria they follows. The patient present in a subacute onset with a rapid progression of less than 3 months of working memory deficit, altered mental status, or a psychiatric symptoms, along with at least one of the followings, like a new focal or a central nervous system findings, seizures not explained by previously known seizure disorders, case of pleocytosis, usually WBC more than 5 cells, and MRI feature suggestive of encephalitis. So along with at least one of the followings into, and reasonable exclusion of alternative causes. For this, we have to do battery of investigations. So with this, we can diagnose a possible encephalitis. We can start the treatment. So if a patient is respond, then we can diagnose it as a probable autoimmune encephalitis. So what is the treatment in autoimmune encephalitis? Treatment is actually standard. In a first line, we have to try with corticosteroids, intravenous immunoglobulins, or a plasma exchange based on the patient's response and severity. Second line is immunotherapy. We can try with cyclophosphamide, rituximab, or both. And simultaneously, we have to search for the tumor. We have to remove the removal of the tumor, which actually fastens the recovery. Apart from that, most of the patients need support to treatment like antiepileptics, antipsychotics, antidepressant drugs, mood stabilizers. Sometimes patient need analgesics, especially neuropathic analgesic drugs. This is the treatment as a nutshell. First tier, second tier, we can call it as. Sometimes patient, when comes to in a late stage, when in a severe, we can use alternative therapy with tocilizumab or a low dose interleukin-2, and sometimes steroid sparing agents for maintenance therapy, azathioprine or a mycophenolate. Sometimes these patients after recovery needs prolonged chronic treatment to avoid relapses. So once you diagnose, look for the tumor. If you are able to search for the tumor with CT, abdomen, chest or pelvis, mammography, pelvic testicular ultrasound, it is okay. Otherwise, what guidelines is you have to do PET CT. That is to see the glucose metabolism, hypermetabolism, and hypometabolism. And if no tumor was found, and repeat the search for every 6 months for up to 4 years. So that much risk is present for the tumor in autoimmune encephalitis. So first you try with immunotherapy trial, as I said, methylprednisolone 1 gram per day for 5 days, or intravenous immunoglobulins 0.4 grams per kg body weight for 5 days, or a plasma exchange. And sometimes some people may need combination of IV methylprednisolone and IV immunoglobulins. If they improve, you can land in the post-acute or chronic treatment like oral prednisolone, methylprednisolone, You can use monthly IVIG, mycophenolate, methotrexate, azothioprine, and rituximab. But problem comes is if there is no improvement, we have to go for the second line treatment with the rituximab or a cyclophosphamide. So in a case of relapses, you have to again check for the PET scan, and you can go for the, you have to must start with again with the same immunotherapy trial. This is the algorithm for diagnosis and treatment. So moving this is what is the serological based classification. Some it is a so far they have diagnosed these varieties of types of autoimmune encephalitis based on the antibodies what they found in the CSF or blood. The commonest one is the anti-NMDA receptor encephalitis, followed by LGI1 antibody encephalitis. Third one is the containing associated protein like protein antibody encephalitis, anti-GABA receptor encephalitis, anti-GABA A and GABA B, anti-DPPX encephalitis, anti-GAD65 encephalitis, anti-M4 encephalitis, anti-immunoglobulin like protein disease, glycine or antibody encephalitis, and few people included Hashimoto's encephalopathy also in this scenario. And latest one is the myelin MOG antiprotein antibodies like myelin oligodendrocyte proteins, KLH11 and GFAPs. In this all these cases, these antibodies are we can find and which attacks against the cell surface or intracellular synaptic. So NMDA, AMPA, GABA B, D2 affects the cell surface, MA2HU affects the intracellular. Mostly these are the onconeural antibodies, and intracellular synaptic GAD65. So based on this, the people will patients present with a different kind of symptoms. So they affect the synaptic cleft, so which produces the alteration of synaptic function. They present with a memory, behavior, cognition, and psychosis. So the patient are present with refractory seizure status epilepticus. We can consider these patients antibodies to GABA A or GABA B and NMDA receptors. If they present with psychiatric disorders, we can consider the NMDA or AMPA. And encephalopathies of unclear etiology, frequent presence of any type of antibody, that is usually in we can see the seronegative autoimmune encephalitis. And MRI shows limbic encephalitis, and patient present with this tumors, we can consider it is seen in GABA A, BR or AMPR, and associated with viral infections. And this is the anti-DMA, demyelinating disorders. So based on this one, they have given some few or 3-4 clinical features to diagnose the different kinds of autoimmune encephalitis. Coming to the NMDA, this is the commonest one. So I put it as this slide is present like from the common to less one frequency based on the frequency. So this is the commonly seen is the NMDA receptor autoimmune encephalitis. This is mostly seen in young, often females, acute onset and present with a mixed psychopathology and complex movement disorders. So as this is the common, I put this slide. In these people and NMDA receptor encephalitis presents with a viral prodrome like a simple cold and cough and flu-like symptoms initially, followed by psychiatric manifestations like anxiety, paranoia, and social withdrawal, followed by severe cognitive dysfunctions. And later, if you won't treat at this point, these people land up with a movement disorders like a orofacial dyskinesia, dystonia, or choreoathetosis, followed by epilepsy. Finally, as I initially told, these people came with landed in ICU with a disorders of consciousness, severe autonomic dysfunction like hyperthermia, fluctuations of blood pressure, tachycardia, central hypoventilation, increasing frequency in seizure frequency. So in this case, 30% of the patients MRI shows mesial hippocampal flare hyperintensities, and in CSF shows antibodies with lymphocytic pleocytosis. EEG shows partial or a generalized epilepsy with extreme delta pressure. This is the characteristic feature EEG finding for NMDA. Cancer screening in 50% of female patients will have often a ovarian teratoma. But thing is, these people, most of the people, if you diagnose and implement treatment early, respond to the first tier treatment. They are not responding, then we don't have no option. We have to go to the second tier. So this is about the NMDA receptor, followed by LGI1. These people present with often males and elderly people present initially with a frequent focal seizures. They have typical focal seizures like a facio-brachial dystonia seizures. This is the characteristic feature of this LGI1 autoimmune encephalitis. We have to suspect when the patient present with a facio-brachial dystonic seizures, followed by amnesia. And one interesting thing is these people present with a severe hyponatremia, like a SIADH. So this is the diagnostic features, clinical features for LGI1 autoimmune encephalitis. Followed by GABA B. In this patient, people are elderly people. Age also important to diagnose this all varieties of autoimmune encephalitis. This present in elderly people, typical limbic encephalitis with memory impairment and seizures. And next one is the Casper-2. This is also found in elderly people, usually males, and these people present with chronic behavioral changes, cognition, and severe neuropathic pains and cramps in the legs, and sleep disturbances and ataxia. So these people will present with a severe neuropathic pains and cramps, prolonged time. So this history makes a diagnosis for Casper-2. And GABA A, this is the broad range of symptoms these people present, but typically they land up in our intensive care unit like a status epilepticus, and MRA having a typical prominent cortical and subcortical intensities we can see in a T2 and flare MRI lesions. And now this is also nowadays able to diagnose by the clinical features MOG, myelin oligodendroglykoside antibodies. This seen in young patients, they present to our intensive care unit with a ADM, acute demyelinating encephalomyelitis, with optic neuritis and transverse myelitis. Optic neuritis and transverse myelitis. So these people also will respond very well if you properly diagnose the MOG. Next one is the glycine, or this is the broad range of symptoms they present, but these people are present with a rigidity, brainstem features, confusions, and hyperplexia. And next one is the AMPR. These are middle-aged people. They present with the limbic encephalitis. Most of the time, these people are associated with lung cancers. Another characteristic features of AMPR. And DPPX autoimmune encephalitis is present in the middle-aged people. They have a gut and brain relations in these patients. That is why these people present with a prominent diarrhea, weight loss, myoclonus, and hyperplexia. So this is the autoimmune encephalitis having a presented with a diarrhea. And the last one is immunoglobulin-like addition protein autoimmune encephalitis. This present with elderly people. So most of this kind of people attended to the pulmonology OP because they have marked sleep disturbances, bulbar weakness, and diverse movement disorders. Sometimes these people are present with a stridus. So these people needs long-term, before presenting to ICU, these people getting long-term BiPAP missions also because of misdiagnosis. So based on these are some of the characteristic prominent features helpful in diagnosing the autoimmune encephalitis. That is why these have a wide variety of symptoms. People goes to the different primary consultants because these people are present in a different way. Some people present with the diarrhea, some people present with sleep apnea and sleep disturbances, and some people present to the orthopedician because of neuropathic pains and cramps. And those people come to the neuropy or with the sleep seizures and psychiatric symptoms also. So another one is the paraneoplastic autoimmune encephalitis, which is not covered in that. These antibodies are usually against intracellular targets and often referred as onconeural antibodies. These are anti-HU, MA, CV2, CRMP5, and ampicillin. This prognosis is generally poor because this is damages the cells. Actually, intraneural antibodies, this damages the neurons. But some improvement will occur with tumor removal. So some people, they have kept Hashimoto's encephalopathy also this group. This is the rare syndrome which is associated with also Hashimoto's thyroiditis. These people present with cognitive dysfunction associated with hypothyroidism or hyperthyroidism, sometimes euthyroidism also. These people present acute presentation with a stroke-like episodes and are a prolonged seizures. Sometimes overlap also happens. So that to diagnose Hashimoto's encephalopathy needs a expert-derived clinical consensus criteria. So in this patient, we can see the elevated anti-thyroid antibodies like thyroid peroxidase antibodies, anti-thyroglobulin antibodies in the blood and CSF. Thyroid hormones vary from patient to patient, often normal. EEG shows abnormalities in the majority of patients. MRI also normal. Tumor is rarely seen. These people, if you diagnose, they will respond properly to the first line treatment. So last one is the seronegative autoimmune encephalitis. So this group has kept the clinical features are fitting with autoimmune encephalitis, MRI also, but the antibodies are negative. So without any identifiable pathogenic antibodies in this condition, but the what people think that they might have an hidden autoantibody that cannot be detected in current laboratory methods. Maybe in coming days may be able to diagnose. And other mechanism for this seronegative autoimmune encephalitis, they might have a non-antibody mechanism such as activated T cells, microglia, macrophages, or cytokines. So this non-antibody mediated mechanism, which is cause for this kind of seronegative autoimmune encephalitis. So the diagnosis is made after exclusion of other etiologies like infections, tumor, vascular. We have to exclude the other causes for this autoimmune encephalitis when you are wanted to name it as a seronegative autoimmune encephalitis. Generally, these patient symptom signs are we can see all kind of neurological deficits and mostly involve the cortical area, focal neurological deficits such as language dysfunction, motor deficits, and focal seizures. But whatever it may be, the symptoms, severity of symptoms are more in this seronegative autoimmune encephalitis compared to seropositive. Like they have initial MRS scores, more impaired consciousness, more weakness, higher prevalence of abnormal CSF profiles, brain MRI, and poor response to immunotherapy because of late diagnosis. This slide showing the what variety of tumors associated with what type of autoimmune encephalitis. Most of the times thymomas and teratomas we can see. Apart from that, some defects you can see B-cell lymphomas and anti-GABA B and receptor encephalitis. You can see thymomas, malignant melanomas, breast carcinomas. So in some cases, Hodgkin's lymphomas, multiple myeloma. So most of the tumors we have to work up. We have to do when you are diagnosing the autoimmune encephalitis. So this is the selected diagnostic algorithm for autoimmune encephalitis. So we have to do first brain MRI with or without contrast, EEG, serological assay for systemic autoimmune disorders to exclude, and IgG class antineural antibodies, and CSF analysis for cell count, oligocanal bands, IgG class antineural antibodies. Tumor screening is must, which includes serum, CSF screening for antineural antibodies, and whole body PET scan, CT scan, transvaginal ultrasound or abdominal MRI with contrast to exclude the tumors, and initiate the first line immunotherapy after reasonable exclusion of alternative diagnosis such as infections, awaiting for the CSF confirmation of IgG class antineural antibodies. If so, if you start patient having clinical improvement with the first line treatment, we can consider it as a definitive autoimmune encephalitis. And meanwhile, you send the investigations like for anti-immunoencephalitis workup. If you start treatment, if you improve patients, you can categorize as a definitive autoimmune encephalitis. Still, patient is improved, but neural antibodies are negative. We can name it as a probable autoimmune encephalitis. If there is no clinical meaningful improvement, but positive for antineural antibodies, then we can give the we can consider it as a definite autoimmune encephalitis, and this patient may need second line of immunotherapy. If it is negative, there is no improvement with first line treatment, then you have to search for the other alternative causes must be reconsidered. This is the same algorithm. To exclude the other causes, you have to do, apart from the MRI, brain EEG, CSF routine analysis with infection and malignancy screening, CSF autoantibody panel, TSH, anti-TPO antibodies, anti-thyroid, anti-thyroglobulin antibodies, anti-GQ1B antibodies, tumor screening with hematochemistry, vasculitis workup profile, serum lactate, chest X-ray, CSF AC levels, ultrasound abdomen, and prostate blood serum electrophoresis also important. So what are the pitfalls while diagnosing the autoimmune encephalitis? Autoimmune encephalitis is frequently suspected but is often not present in the following scenarios. Like if it's psychosis in young adults diagnosed with schizophrenia or bipolar disorders, especially if there is a positive psychiatric family history, we can exclude. Positive neural antibodies with low clinical significance. The GAD antibodies having in a serum very low clinical significance, we can exclude. And positive thyroid antibodies with mild memory, mood, and other subjective symptoms, also we can exclude this Hashimoto's autoimmune encephalitis. Patient present with simple tics, Tourette syndrome also we can with. Confused hospitalized patient who are very sick due to medical illness also, it is very difficult to diagnose autoimmune encephalitis in this category. These are the pitfalls. So for this to diagnose, we need proper history. To conclude, so evaluation should begin with a history and physical examination, which is must to diagnose autoimmune encephalitis. And it present with diverse of infections also should be considered, well, because the diverse range of symptoms we'll see in this autoimmune encephalitis. MRI, EEG, lumbar puncture further support the diagnosis. A broad group of antibody tests are used to diagnose. Risk of neoplasms should always be considered. Treatment in this case usually respond with first line. Next you can go for second line. Meanwhile, you have to give the supportive treatment, behavioral treatment, and needed this patient. And one thing you should remember that patient may relapse and should receive appropriate follow-up. So with this I conclude. Dr. Suresh?
Hello?
Hello, sir.
Sir, Suresh sir Lera?
Children, sir.
Is there actually.
So actually, I kept a few MRI pictures. Is the right person you can discuss, that is why. If you're not there, I will.
You will discuss.
Sir.
Is there?
Mida voice ratlada. అన్మ్యూట్ చేయండి సార్ మీది.
నేను చేస్తానండి అన్మ్యూట్.
డేవిడ్, ఎనీ డౌట్స్?
Yeah. Sir, can you send for panel of diagnostic?
Yes.
Can you ask encephalitis panel for autoimmune disease like that?
Yes, yes.
So
Yes,
they
sir.
will do all the
They are
serological tests.
several people they are doing, sir.
What you will ask for investigation?
Yeah, right now we have people are doing anti-mob, and they not all these people things are doing. This is the panel of this thing. Right now, this anti-NMDA they are doing, sir. LG1.
NMDA కాకుండా we can write the panel, no? Encephalitis panel.
In that panel actually, I wanted to keep
all these things.
అదే anti-glutamate receptor, anti-gamma, anti-Caspar2, anti-LG1 and 4-5 only they are doing, sir, at present in India.
NMDA చేస్తున్నారు కదా?
NMDA చేస్తున్నారు. NMDA, GABA, LG1, Caspar, MOG, and this one Hashimoto's also, anti-thyroid immunoglobulins also they are doing, sir.
And Suresh గారు అన్మ్యూట్ చేయమనండి సార్, మీట్ లో ఉన్నారు.
అదే ఆయన చేయడం రావట్లేదు అనుకుంటాను.
Hello.
Yes, sir.
Yes, sir. Yes, sir. Am I audible, sir?
No audible, sir.
Good morning, sir.
Good morning, sir.
Mohan Rao said a very
Yes, sir. Yes, sir.
Excellent and very extensive presentation.
Yes, sir. Very
I expect you to explain what are the different pictures of MRI and what is the type of autoimmune disease.
Yes, sir. Yes, sir. Excellent presentation, sir. Mohan, sir. Very elaborative and very descriptive. Coming to the history, actually, this autoimmune encephalitis, it was described in 2007 by Professor Dalmo. But interestingly, the first case was described by Dr. Carr in 1982. He described this disease in his daughter only. She developed Hodgkin's lymphoma, finally succumbed. So he named it as an Ophelia syndrome. Ophelia, as you know, Shakespeare, Hamlet novel. So Ophelia, she developed madness later on. So like schizophrenic-like symptoms. So first description of autoimmune encephalitis, which was described by a general physician, Dr. Carr, he has described in 1982, a young girl with a psychiatric manifestations, later on succumbed. So later in 2007, Professor Dalma has developed all these cell-based assays and all. Initially, he has developed NMDA receptor, this NMDA autoimmune encephalitis, more of psychosis kind of thing in the young girls. And very young babies, they present like movement disorder. And the first decade, after first decade, 10 to 20 years, they present like psychiatric symptoms and other things. So initially we thought of psychosis, and most of these patients will be admitted under the psychiatric care. So as Ansar has already informed us, so it's like multidisciplinary, it needs multidisciplinary approach, both in the therapeutic and treatment wise also. Coming to the imaging findings, as you all asked about this one. So first one is that temporal lobe, medial side, that is medial limbic encephalitis. That is a classical feature of medial temporal lobe. Both sides are involved, and lateral temporal lobe is paired. Lateral is outside, that is paired. So coming to the medial side, bilateral symmetric medial side, it's the limbic encephalitis. There's so many DDs. Autoimmune encephalitis is one of the predominant etiology. In our scenario, like in the tropical countries, at times neurosyphilis can present like this, HHV6 can present like this, sometimes herpes virus infections also present like this. That's why interpreting the only one imaging modality may not be sufficient. It needs a complete information from the imaging, EEG, LP, and serology. So even if the serology also, if serum is NMDA positive and CSF is NMDA negative, as all discussed about, Mohan has discussed about that psychotic. Young psychotic, sometimes if you take 100 patients of young psychotic patients, 10 to 13% will be have positive serum NMDA positive results, but they will have negative CSF. So both you have to do, serum and CSF, both should be positive, then only you can consider. Only serum positivity may not give you correct conclusion. Coming to this second cortical and subcortical involvement, predominantly subcortical involvement, basic frontal and occipital. This predominant is for GABA receptor antibodies can present like this. They present like status epilepticus, multifocal seizures, and then encephalopathy with tumor-like presentation like this. You see, extensively involved subcortical involvement, mostly GABA B. And David sir, you asked about this one, sir, commercial kits. Commercial kits in India, they are doing CSF and serum both, but only limited. NMDA, VJKC, AMPA, and GAD. This MOG initially it's in the NMOSD, like neuromyelitis optica spectrum, because they have optic neuritis and myelitis. So initially the NMO means like neuromyelitis optica spectrum disorder. Now MOG they included this autoimmune encephalitis, because it presents like ADM and meningeal enhancement also. Initially thought of autoimmune encephalitis, most of the time they'll affect the encephalon or myelin, and means spinal cord, brainstem, or at times in the peripheral nerve, hyperexcitability syndromes like Casper. So meningeal enhancement, initially thought of like meningitis, but MOG is this thing. It can affect the meningeal and cortical structures also. So if you do the LP lymphocytic predominance, and if you do imaging, some cortical lesions are there, and we may initially misdiagnose as tuberculosis, because cortical involvement is there, raised protein and raised lymphocytes also. So we have to check the other things also. So in this autoimmune encephalitis, initially we thought of meningeal enhancement is rare, but now the cases are coming up with the meningeal enhancement. It's also complicating the diagnosis once again. The meningitis and meningeal enhancement is there, or meningeal involvement is there in some effective causes. Now this mark we have the hands of it. Here Monser is described last, that one. See last slides. Post contrast enhancement and that meningeal things. In GAD also sometimes presents with subcortical and then what you call striatal involvement also. NMDA, most of the time MRI will be normal only. Sometimes they present like cortical ribbing kind of thing, and subcortical involvement and limbic involvement also will be there. But most of the time NMDA is negative. Most of the time NMDA MRI will be negative only.
Excellent explanation, sir.
Yes, sir.
Sir, if a patient is having positive for this autoimmune encephalitis,
Yes, sir.
can we stop all this antiviral and antibacterial
Yes, sir. Yes,
antibiotic?
sir. Yes, sir. Yes, sir. That only clinical phenomenology is very important, sir. Autoimmune
Or will
encephalitis.
continue?
No need for the continue of antiviral or antibacterial.
Or antivirals.
Yes, sir. Because that only, sir. Sir has presented first slide. Now it's like some febrile illness followed by encephalopathy. Most of the time, the NMDA receptor antibodies.
Majority will continue, no?
Majority will continue, but there is no need to continue, sir. History is very important, sir. Autoimmune encephalitis is more of subacute, not like acute presentation. So some febrile illness, sometimes some viral illness, followed by encephalopathy. In viral encephalitis and all, they'll have fever also. During the episode also, they'll have fever. In autoimmune encephalitis, fever is very rare, sir. Continuous fever is very rare. So some fever followed by immune triggering event, then this thing. So more of subacute to chronic kind of thing is autoimmune encephalitis. And more of acute kind of thing is acute bacterial meningitis or acute viral meningoencephalitis.
Sir, another question.
One more, that I'll complete this one. And one more thing is to complicate this one, sometimes after herpes virus infection, sir, it is more, they'll have this anti-NMDA encephalitis also. So herpes virus leading to anti-NMDA viral encephalitis. In that scenario, initially we can give IVSA, but once it developed NMDA encephalitis over immunotherapy, sir. So herpes related NMDA encephalitis is another concept, sir.
Yes, sir.
Yes, sir. Yes, sir. Please.
Sir, another one, if patient having non-autoimmune encephalitis, like what he said, T cell, T lymphocyte, macrophage encephalitis. What is the treatment for that?
MOG encephalitis mostly is present in the pediatric population. encephalitis like present, ADMA kind of thing, some viral illness followed by the encephalopathy. So most of the time, this mock encephalitis used to respond with steroid, first line therapy only. But 25% of the mock patients, they may need secondary line of management like rituximab and all. I have one patient, I have tried rituximab, there is no improvement. Then we have tried tocilizumab also, is also not improved. This went to Niemann's also, they have also tried tocilizumab, but no improvement. So monthly methylprednisolone we are giving, and on top of that, we are giving IV, IG monthly. But some mock patients, most of the mock patients responds very well. 75% of the mock patients responds very well to the chemotherapy first line, that is methylprednisolone only. Some patients, but 25 patients of the 25% may need strong immunomodulation. But anyhow, considering this severity, sir, so mock affects mainly the optic nerve and spinal cord. One attack of the spinal cord causes more damage because the highly dense fibers will be there only. So to prevent the second attack, we should be very aggressive, sir, mainly in the NMDA and MOG. If you take the natural history of NMDA encephalitis and MOG encephalitis, so they'll have this cognitive decline and this recurrences of the symptoms also will be more. So now we are going aggressively with the NMDA and MOG, sir. But MOG responds very well to the steroids. 75% will respond to steroid only. Later on, this rituximab and all other things we have to try.
Thank you, sir.
Yes,
Any
sir.
questions from audience? Hello? Satish and Srinivas, Rani madam, Varalakshmi. Hello? Satish?
Nah,
Na.
we last 1 year low, we came across 2 to 3 patients initially presented as like routine CNS symptoms like mild fever, altered sensorium, seizures. So initially we thought it is infective. Then patient is not improving. Then we have gone to the next workup. So workup is slowly expanding, and finally after day 6 or day 7, patient is not improving. Then getting a thought of it could be autoimmune or paraneoplastic. Then those workups started. Finally, we landed up into the diagnosis of autoimmune. Both patients were improved after IVIG.
Why
That's how
can't you do
retrospectively we
initially?
found. Yeah.
Can we do initial workup itself for this autoimmune profile also?
Yeah, we did
Curator?
not. That's what I'm telling. We did not
Mhm.
have that idea. Initially, we thought it is simple meningitis like thing.
Yeah,
Then
usually everybody
when
learns.
we are not getting any improvement after 2 to 3 days of antibiotics, then further MRI is showing some changes. So after that, this idea comes, and then we have sent the investigations and we got the diagnosis. Retrospectively, we thought that it is like autoimmune. There is no definitive diagnosis. Sometimes even the whatever the previously discussions, GAD antibodies, NMD antibody, all those things we are done. But
Yeah, yeah.
those also seems to be negative. So that's what Mons are telling, that all patients may not get positive also. So maybe we had those patients, we treated, and we don't have a definitive diagnosis to prove that it is autoimmune.
Yeah, correct. Sometimes
Yes,
seronegative.
sir. Can we send the first day itself autoimmune profile also along with this other test?
No, sir, depends on clinical history, sir. That's febrile illness followed by encephalitis. If there is no history of fever, any strong suspicion, like you see in the NMDA encephalitis, children will get the peculiar perioral movements like chewing kind of thing and other things. In elderly patients, this LG1 antibody, they will have facial-brachial dystonia. Sometimes piloerection, rectal bradycardia also will be there. So I have one patient, he has presented with some sensory kind of thing. So left upper limb sensory TAA kind of thing. Later on, he developed some dystonia. I have given him carbamazepine because of the sense. I thought of focal seizure versus TAA. After the carbamazepine, I developed rash. So that is also indicative. I don't know why some people in this LG1 antibody mediated encephalitis, if you give carbamazepine or oxcarbazepine, they develop rash compared to the other people. So later on, I thought of hyponatremia is there, they developed rash, and I have done the LG1 is positive. So some specific phenotypes, already Monsar has described phenotypes, like whether it is predominantly movement disorder, predominantly behavior, or any psychiatric symptoms, or in memory issues. Like that, we have to segregate this thing, and then we have to phenotypically, we have to categorize this thing, then only we can send. Otherwise, the false positive, otherwise the predictive value will be very less. We can do, but thing is like clinical and imaging findings, it should be fitting into the other autoimmune encephalitis. Then only it will be positive.
the
No,
same
no
time,
need
it
to
will
send
not
all.
be delay for sending the.
But yes, sir. But thing is like if you have strong suspicion, we can send, sir. What we'll do is routinely we'll send the routine sample and then we'll preserve the sample on the same day only. And empirically, if it is we are thinking of autoimmune encephalitis, start steroid and wait for this thing. If both are negative, then we can give only steroid only. If it is positive, then we go for the IVIG and other rituximab and other things.
Thank you, sir. Any questions?
Clinically and history and the clinical examination is very important, sir.
Yes, sir. Yes.
Sir, not a question, sir, but just
Ah.
a
Varalakshmi?
Hello.
Yes,
Yeah,
yes, ma'am.
Varalakshmi.
sir. Not a question, sir. Like sir said, a lot of seizures. We've seen refractory seizures. We've worked up, and then we have worked in young patients. Almost 2-3 patients super refractory seizures. They've responded to steroids. Like Suresh sir said, most of the times empirical, sir, because pending all these reports empirically when they have responded to steroids, we've made an assumption that it is autoimmune and subsequently they have improved. But I think these non-specific symptoms, I think now that we know and we are more aware, it is only recently I think that we are keeping this as one of the differential diagnosis and working out in that direction. But starting an empirical steroid in most of the situations is very tricky because they also have it is kind of a mixed infectious and autoimmune kind of a picture. That is where the challenge lies, and if we have good neurology support and clinical suspicion is where maybe we can get to a diagnosis in these patients.
Yes.
And even personally, like you treated my mother-in-law. I mean, it was a similar situation. Though although the workup came back negative, sir, but she responded initially to steroids. Although
Yes.
there is steady
Yes.
deterioration, so I think that was also one eye opener for me that we should look at autoimmune also as a component even in elderly patients.
Yes, ma'am. Yes, ma'am.
Thank you, sir.
Thank you. Thank you.
Thank you, Mohan Rao sir and Suresh sir, for a nice, very good explanation about this autoimmune encephalitis and rare possibilities of the disease, how to approach and how to treat, depend on the clinical scenario and laboratory, when to suspect these cases and when to start this treatment. So, very good explanation. Thank you, sir, Suresh sir.
Thank you, sir.
Thank you, Mohan Rao sir, for nice presentation and explained everything about this autoimmune encephalitis and diagnostic approach and treatment options. Very good presentation. Thank you all the audience for your active participation. Thank you, sir.
Thank you.
Thank
sir.
you, Mohan sir.
Thank you, sir.
Thank you.
Thank you, Mohan sir.
Thank you, sir. Thank you, sir.